Hi, I'm Nusayba Bagegni. I'm a breast medical oncologist at Washington University in St. Louis, Simon Cancer Center, and I have the pleasure of being here today with Dr. Lammers. And we're here at ASCO 2026 in Chicago, Illinois, here to discuss the evolving landscape in the advanced HR-positive, HER2-negative breast cancer setting. Dr. Lammers, if you could introduce yourself, please.
Sure. Happy to be here. I'm Phil Lammers. I'm the chief of the medical oncology group at Baptist Cancer Center in Memphis, Tennessee. Help to lead our breast program as a breast medical oncologist.
Wonderful. Thank you so much. So we have a lot to talk about today. I remember when I was a fellow, I would tell my faculty, what did you all do before CDK4/6 inhibitors? And fortunately now we have, CDK4/6 inhibitors in the first line setting with endocrine therapy and then numerous options thereafter. We still need more though, right? But also trying to, gather all of the information from the therapies we have now and trying to figure out how to sequence. So the landscape is ever evolving. We have oral SERDs and PROTACs now that have been FDA approved, and the PIK3CA pathway, targeting that, as well as ADCs. So we have a lot of targeted therapies. So, essentially we want to talk about what's driving our decisions today. And so when you're seeing a patient who has progressed on endocrine therapy and CDK4/6 inhibitor, can you tell me a little bit about how you think about approaching next line therapy?
Yeah, sure. Like you said, it's gotten more and more complicated, even just the last few years. Thankfully, we have very efficacious drugs with the CDK inhibitors in first line. But patients are going to progress for the most part at some point in their journey, and having a number of second line options, I think, is wonderful for patients. But like you said, we're always looking for more efficacious drugs to come. And so when we talk to patients about the options in second line, to me, it's really a discussion with the patient about, toxicities of treatment, potential efficacy, talking about sequencing, talking about, how we may be able to access other drugs in third line or fourth line. Most of my patients want to stay on endocrine therapy as long as possible and not move to ADCs, even though they're, looking very effective in this population. But quality of life is very important, and trying to, maintain the patient on endocrine therapy, on oral medicines. Those are things that my patients really, I think, value. And so when we, have those discussions, we kind of touch on all those points and try to come up with a plan. And sometimes we have those discussions, frankly, even when patients are on first line treatment, just to kind of prepare patients for the future.
So I want to touch on or emphasize a little bit more a point that you mentioned, that many of your patients are wanting to move forward with further endocrine-based therapies. So the question that comes up in my clinic oftentimes is, when do we move to ADCs? When do we feel that it's appropriate to continue further endocrine-based strategies? And, one thing that I think about is duration of response, the pace of disease. Are we having visceral crisis now post CDK4/6 inhibitor? Do I need to kind of put the fire out, right? Or do I feel that this disease pattern is still endocrine sensitive? So can you talk to me a little bit about how you see that?
Yeah, so I think the biology is very different from tumor to tumor, patient to patient. Certainly we have varying levels of ER positivity. We have disease that's more high grade. And so patients will present, like you said, with different presentations kind of as they move into that second line. Some patients progressing rapidly, some patients progressing more slowly. So those are definitely things we take into account. But I think the biology of the tumor is something that you really have to understand, or at least try to understand, and somewhat base your decisions on next line of therapy, based on the biology as part of the treatment decision making, along with the other things we talked about, toxicity and quality of life issues.
And some of that biology gets to next generation sequencing and ctDNA testing. And fortunately, just over the last several years, we've had the access to ctDNA testing. And previously, I remember it would take a couple of weeks to get back. Now, sometimes 7 to 10 days, you have that result back. And as you mentioned, a lot of times I'm getting that testing up front to learn a bit about the biology. Am I seeing a PIK3CA mutation or some, an AKT alteration? Am I seeing ESR1, is that going to impact, what I expect the disease course to look like? And then also to identify next therapy options. So can you tell me a little bit more about how you would use that within your clinical practice?
Yeah, so like you mentioned, next generation sequencing is standard of care now, and the timing of it may vary a little bit. Generally, in my practice, I try to get it as early as possible so we can kind of make that plan for the future. And so usually when a patient is diagnosed with metastatic disease, whether it be de novo or after recurrence, we're usually trying to obtain tissue and send that tissue for testing. And then as the journey moves forward, we are using ctDNA quite a bit to evaluate for changes in the biology of the tumor. We now know quite a bit more than we did years ago about the development of resistance with ESR1 mutations, and now we have drugs that have been shown to potentially try to overcome that resistance on progression with our oral SERDs and such. So we are doing this as a comprehensive way of managing patients and making sure that you have the tissue testing at time of first recurrence. But as patients progress, especially if the progression, is a little outside of what you would think, if they all of a sudden develop a new liver metastasis but have had pretty stable disease for a while, or something's just clearly different, I still will try to get even a biopsy,
Completely agree. Yeah.
because, you get the NGS, you'll see that the changes in the mutational profile, but, sometimes just the changes in the IHC is very important as well.
And basic biomarkers, right? HER2.
Correct. Yes.
So sometimes it's HER2 negative and it's bone only for a long time. And then very abruptly, you may have a HER2 positive or amplified clone.
Absolutely.
Yeah.
But so generally my practice is to do, liquid biopsy ctDNA at every, potential progression. And, there's evolving data that maybe we should be following patients who, have stable disease on first line with, serial ctDNA too. So
SERENA-6 data.
Correct. Yeah. We participate in the SERENA-6 study, so we have some experience with that. But so I think it's evolving, but certainly a standard of care to, every treatment decision you make in first and second line, I think has to be based on biology with, biomarkers and NGS as part of that strategy.
So when we're seeing a patient that relapsed very quickly within or while on adjuvant endocrine therapy, a common practice that I'm doing now is getting that ctDNA to identify if there is a PIK3CA mutation because we have the INAVO120 data. And in that situation, I may consider fulvestrant, palbociclib, and inavolisib. Let's say that we're beyond that point, and now we're looking at second-line therapy in a patient who had endocrine therapy and CDK4/6 inhibitor. So can you let me know, if you identify PIK3CA mutation or AKT or PTEN deletion? How, what are you doing at this point in terms of identifying next therapies? Let's say that there is an ESR1 mutation there as well.
Yeah. So, mutations in the pathway, whether it be PI3 kinase, AKT, PTEN, generally tend to be canonical mutations, are going to be present when you first make that biopsy and then generally do not change over time. But as we mentioned, ESR1 mutations, definitely can develop, and there can be other changes as well. But so if I identify a patient who has an estrogen receptor positive breast cancer with an alteration in that pathway, when we come to progression on CDK inhibitor, that's when I'm really usually try to target, the mutated protein in that pathway. Now it does become more complicated if they have an ESR1 mutation as well, but generally, I think that TrueCap is a very good option for patients in the second line in those situations, whether they have an ESR1 mutation or not. In my practice, my plan is usually to target that pathway in the second line, especially now that we have, new data, from studies like EMBER-3 with combination with ESR1 and CDK inhibitors on rechallenge, So, generally in my hands, I haven't moved from CDK directly to CDK rechallenge. That's just the way that I've kind of come around it. And usually what I want is something kind of different, a different way to target the tumor coming off CDK progression. And then, potentially having the option to come back for CDK rechallenge, with an oral SERD potentially in kind of a third line situation now. But I do find that TrueCap is plus Fulvestrant is a very nice kind of second line option for a majority of patients who have an alteration in the pathway.
So you mentioned Capivasertib. So what stood out to you from the Capitello 291 data, which was a study that enrolled patients who had progressed largely on a CDK4/6 inhibitor. About 70% of patients had received that in the advanced setting. They did allow for prior chemotherapy. Only about 20%, a little bit less than 20%, had prior chemotherapy. So what stood out to you in terms of the efficacy data from that study?
Yeah, I think the efficacy data was promising, was nice. To start with, I appreciate the patient population that participated in Capitello 291. Previous studies and with PI3 kinase inhibitors, et cetera, have largely excluded, patients with existing diabetes or with hyperglycemia at baseline. The way that this study was set up included patients, with diabetes, as long as they were not on insulin and had a hemoglobin A1C of less than 8%. And in population patients I serve, that's a pretty common
Likewise.
comorbid condition. We have a lot of patients in our catchment area who have metabolic syndrome, have diabetes or diabetes and on oral drugs. So the fact that those patients were included, I think, speaks highly of our ability to apply the results of that study to our patient population. And so, in general, it was very nice to see a PFS benefit of 4 months, basically in the altered population that was studied in that in the Capitello 291 study. So very, efficacious, data. We saw very efficacious data. The response rate approached almost 30% on that study, I believe. And so, we generally think of endocrine therapy as not producing much of a response, but more of just kind of a sustained result in progression-free survival. But it was nice to see a response because some patients, like we've talked about, may benefit from a response actually in the second line. So I think, from the data on efficacy, it was a clear benefit over Fulvestrant alone and a patient population that really, in a lot of ways, resembles the patients that I treat in Memphis.
So many of the prior PI3 kinase inhibitors, obviously this is a pan-AKT inhibitor, but the other agents that were previously approved or subsequently approved with inavolisib, they really had restricted patients who didn't have, diabetes with the A1C about 6% or around that realm. And so also where I practice, that is a common concern. And in terms of monitoring and so on, that we'll get into a little bit of the AE management and safety profile and so on. So in what types of patients do you feel this approach of using these pathway inhibitors the most meaningful?
Yeah, so, certainly we're talking about patients who have alterations in the pathway, PIK3CA, AKT, PTEN, which, when we look at, retrospective studies and studies looking at large numbers of patient samples, we've seen that that's probably about 50% of patients with ER-positive breast cancer. So, there's a large number of patients who are potential option, have this potential option as a second line treatment. So most of my patients, I will talk to you about that in the second line, but as we've discussed, it may not be right for everybody. And sometimes we have a patient who has a very fast progressing disease who you may think that you need to go forward with something like, an ADC or chemotherapy to get a quicker, response that's potentially more durable in that more aggressive subtype. But, a lot of patients will come off, CDK with progression and have fairly slower progression or, new bone lesions, those sorts of things. And those patients, I think, are good candidates for the TrueCap Fulvestrant combination.
So if you also see an ESR1 alteration, what would you do in that case? That's a common question that I get in the co-mutated tumors. We have the oral SERDs, we have oral PROTACs. Fortunately, we have newer clinical trials that are starting to read out or, of recommended phase 2 doses. Obviously, this is all off-label, right? But, how do you see that moving forward?
Yeah, we get that question a lot. We talk about that a lot at our tumor conferences and such. But obviously, we don't really have head-to-head data of oral SERDs versus true cap fulvestrant combination. And single agent oral SERDs or PROTAC inhibitors, I think do provide some benefit to a population, but to be honest, on those studies, the population that benefited was a fairly small percentage of patients, and the benefit was not, robust for a lot of patients, unfortunately. And to me, the emerging data with combination with those drugs is very exciting. And so I think there's definitely a role for, looking at oral SERD therapy for ESR1 mutated breast cancer. But I think, like I talked about before, I think trying to kind of, figure out the sequencing and what's going to work for each patient. And to me, it makes kind of sense logically to kind of take a break from CDK before you re-challenge right away. So I usually like to have a line of therapy like the true cap fulvestrant is kind of my second line in that population, and then potentially come back in the third line with an oral SERD, potentially in combination with a CDK inhibitor now with the emerging data. Yeah.
So we've had the luxury of having the Elevate trial where we combine elacestrant plus capivasertib. So I've enrolled a number of patients in that, and just being able to identify these are driver mutations, right? These are resistant. Obviously, this is a tumor. If it's ESR1 mutated, it's using that pathway. And we know it's kind of that addiction, right? It's addicted to that. And so being able to target the mutations versus switching to something that perhaps may not necessarily target, but, if the pace of the disease is escalating. So you mentioned, prior duration of therapy is the question I'm getting to, but you mentioned there are some patients that if they have visceral crisis, I may need to switch them over to an ADC, versus if we have some slight progression, I may then feel best about capivasertib if there's that mutation. So tell me a little bit about how you see that in terms of prior duration of therapy. We had some subgroup analyses, readouts from Emerald and also from the Destiny Breast 06, and how you would use that to determine your next line therapy.
Yeah, it's a great question. And I think all those factors play into choosing kind of the second line treatment for our patients. And like you mentioned, we've seen on the Emerald study that, it seems like the patients who are progressing faster maybe didn't respond as well to the oral SERD as patients who had longer disease control in their first line of therapy. So, I think there's something to that. I think there's something in the biology of that to consider. And those may be patients that you definitely want to be able to access, the oral SERD in that situation. Again, most of our patients who have, that subtype of breast cancer, that kind of more slowly progressing subtype, will be able to access 3, sometimes 4 lines of endocrine therapy. Yeah. So I think, you have to kind of think long-term for those patients and not necessarily, focus on one particular indication over another, knowing that they're probably going to be able to access, multiple lines of therapy in the future. I think the Elevate study that you mentioned is really one that we're excited about and looking forward to seeing data in the future about actually combining an oral SERD together with the TrueCap drug, just given the potential to target the driver mutation and the resistance mutation, like you mentioned, with the same treatment, and hopefully keep patients on treatment even longer. But yeah, the pace of progression, the duration that they were on CDK inhibitors are very important when we're thinking about second line options.
So you mentioned also prior comorbidities, if they have diabetes, and so on, other patient factors. So let's kind of dig a little bit deeper into the safety profile of capivasertib and of these PI3K pathway inhibitors in general. All the agents that we've had prior to that, with alpelisib, for example, we do see a fair amount of hyperglycemia and diabetes, and really have to counsel patients very aggressively about that, diet, and potentially having endocrinology involved, rash, diarrhea. So can you walk me through a little bit about the safety profile of capivasertib and how you counsel your patients about how to mitigate some of that.
Yeah, certainly. As you mentioned, the various inhibitors that have been used in this pathway all have some commonalities in terms of toxicities, and hyperglycemia is certainly common amongst any of the drugs. And as we mentioned, the Capitella 291 study, included a kind of a broader patient population, patients who could have diabetes already on oral drugs, but not requiring insulin. So in terms of hyperglycemia, when we talk about using the TrueCap drug, it's something that I counsel patients very extensively on. Patients who maybe have diabetes and on oral drugs, we want to make sure that they are optimized on their regimen, and sometimes it means having them meet again with their endocrinologist or their primary care who's ever managing the diabetes to make sure we're starting from a place that's as well controlled as possible. I think patients who have kind of metabolic syndrome, but maybe not a diagnosis of diabetes, are patients who are, I think that I have to kind of watch very closely when we initiate this drug. I have not been prophylactically starting medications. I know some people around the country do that in terms of like metformin for patients, but I generally take the approach where we are going to monitor patients very quickly. And if you look at the Capitella 291 study, I think the median onset of hyperglycemia was about the 2-week mark. So in the first week or two, you usually see the elevated blood sugars. So I usually bring my patients back about a week after starting treatment just to kind of do a blood check and just to monitor them very closely, especially for the hyperglycemia and diarrhea, which both have very quick onset on starting the drug. So to me, it's really about education. It's about making sure patients have access to medications that can, improve the hyperglycemia if it does present itself. But not every patient is going to get it. I do have patients that I treat with this that do not get hyperglycemia. So it's not 100%, that's for sure, but it is common. The diarrhea, I think, is pretty common as well. I think on the study, maybe about 70% of patients had any grade diarrhea. And, I have fellows in my clinic, and I talk to them frequently about grading of diarrhea. And I talk a lot about, even grade 2 diarrhea can be really kind of life-altering for patients on a day-to-day basis. So you really want to be on top of that from the beginning. So I usually do make sure patients have a prescription or have Imodium, at home to kind of start taking right away. So if you have any diarrhea, just get on top of it. Again, I haven't really prophylactically treated patients, but what I found is that if you counsel them really well and talk to them about having that, drug available, usually if they start it right away, it usually can be controlled. But again, I see patients very quickly after we start this drug in clinic just to kind of make sure that we can mitigate any, diarrhea that comes up right at the beginning. But usually I found it to be manageable and often can keep patients on the same dose with adequate, management of the diarrhea. And then the other, major side effect that we watch out for in this pathway is rash, and that's can be a little bit difficult, I think, to control sometimes with various agents that are used in this pathway, and that also, I think, the onset can be a little bit later with the rash and then the diarrhea and the hyperglycemia. So that's something that we kind of continue to counsel patients about as well. I have actually kind of moved to a prophylactic approach with antihistamine. I don't know if we really have any data for that, but it's something that I think, most patients tolerate. And Memphis, where I practice, is kind of like the allergy capital of the world, I think.
Okay.
So a lot of people are on antihistamines anyway for allergies.
So you're covered. You don't have to add another medicine.
Usually not. And if I do, I just say, oh yeah,
Yeah.
I take that sometimes for allergies. So I found that just to be one way to help to try to mitigate that, but that's something you have to really counsel patients on as well and make sure they're aware. And if, the rash does come on and is, grade 2 or 3, usually we're thinking about steroid type treatments at that point. So these side effects are fairly common, and you definitely have to, be aware of them and make sure you're counseling patients. In this pathway, sometimes some of the inhibitors have had more stomatitis issues. We haven't seen a whole lot of that with TrueCap based on the Capitella 291 data. So that's a positive sign, but, I definitely talk to patients about that potential as well. but it's mainly the hyperglycemia, diarrhea, and the rash that I'm mostly focusing on with patients.
Yeah. And I do tend to recommend at least a few days prior to starting. Ideally, if it's like a week, like if I'm talking to somebody about the regimen, I'll say, let's go ahead and start the loratadine or cetirizine now, as we're working on getting the therapy approved. And so I do have them take it once a day. And then if I've had a patient develop the rash, depending on the grade, sometimes I'll go to twice a day.
Okay.
That tends to take care of it. I did have one patient who had a more severe rash, just kind of more diffuse, and we did, hold the therapy, did the twice a day, did some topical steroids and oral steroids for a few days. And then ultimately we did need to dose reduce, but did beautifully after that.
Yeah,
I really did quite well.
that's good to hear.
Um,
Have you done any prophylactic metformin in your patients?
So I did quite a bit of that with alpelisib. I will say that I may have done it for a couple of patients, but I get that A1C. If I see pre-diabetes, I haven't really seen that go into full-blown diabetes in my patients, but we do a lot of counseling on diet and, have them meet with a diabetes educator. Usually to get them in with endocrinology, it takes a while, but with diabetes educator, we're usually able to do that pretty quickly. For some who are willing, sometimes we'll do like the Dexcom, like the continuous glucose monitoring, and that actually helps. They're like, I see it there in front of me and I'm able, I ate those grapes, so now it's high. So I need to, be cautious about my diet.
Yeah.
So that kind of ongoing, information coming at the patient, I found that can be very helpful. So I've done it in a few situations. You have to be careful. I usually do the extended release because obviously you can see diarrhea with that.
Right.
So I also like to start that when I'm giving the antihistamine, just so I know that, what's causing what because of the GI toxicities. In terms of diarrhea, I do, prescribe the loperamide, as you mentioned, 2 at the first bowel movement, 1 thereafter. Let me know if you're having more than a few. And, I think that most of the time that's been pretty well managed. The grade 3 rates was about 9 to 10% or so. So I think overall, it's different from what I've experienced with some of the other, pathway inhibitors.
Yeah.
And, fortunately with the hyperglycemia, again, grade 3 rates was about 2%. So just close monitoring. Have you done titration, dose titration?
So I have for a subset of patients, again, who I think may be at higher risk of developing some side effects, particularly the hyperglycemia.
And some are worried about side effects.
Correct, so, just about any drug anymore, when I give a handout about, potential side effects, patients get very worried because it lists every potential thing possible. But certainly I think patients in particular, when I start talking about the hyperglycemia and the diarrhea, patients, sometimes do get more concerned, especially with the hyperglycemia. So, I think I've done that a few times where we started a lower dose and try to kind of work our way up. I had one patient I started lower dose and she did beautifully for the months, and she just always refused to go up on the dose. So I think that's one of the concerns, is if you start a patient at a lower dose, sometimes they may be unwilling to titrate up and potentially make it a little bit more benefit at a higher dose. And I don't know if the data is clear on that yet, but so most patients I do try to start at the standard dose, 400, and manage the side effects from there.
So with Capivasertib, it's dosed 4 days on, 3 days off, twice a day. Many of our patients are coming off a CDK4/6 inhibitor where they're doing it 3 weeks on, 1 week off. So I think many of them are kind of used to a change and not having continuous dosing. I tend to say, let's do it Monday through Thursday and then have a long holiday weekend, because otherwise it can be very confusing. And did I take the 4th day or did I extend? And how do you counsel patients? Do you give them a calendar? Do you kind of write it out? Because obviously it's a different dosing schedule.
Yeah, I do things very similarly to how you do. I say, Monday through Thursday, let's do it, and then you get a long, weekend to recover and get back on it on Monday. But usually, yeah, my nurse will sit with the patient afterwards and develop a calendar just to make sure that they understand. And I think our pharmacist does a very good job of talking to patients about it. And the medicine now, I think, comes in blister packs. When it first hit the market, it was just in a bottle, and that made it tougher, I think, for patients to remember the schedule. But I think having the blister packs is nice, and just continuing that counseling at first prescription is important, I think, for those patients.
And it comes in 160 milligram and 200 milligrams. So depending on what dose, if you're doing 400 milligram, then it's 2 pills. If it's 320, then it's 2 pills of the 160. I've had some patients where we've talked about, even with abemaciclib, where now there's that potential, improved tolerability with dose titration. I tend to actually start the first week once a day.
Okay.
And then go to twice a day. Obviously, I know all about the half-life,
Right.
but if I have time and we're not needing to get a response right away, I'll say the first 4 days, let's just do it once a day. Let's take the 3 days off, and then the next week we could do it twice a day. The other thing is monitoring glucose, because there has been reports of DKA, and if you're seeing the patient, if you're doing that Monday through Thursday and you're seeing them on a Friday, or if you're seeing them on a Monday and they've been off, you may be missing some of that hyperglycemia as well. So you have to think about when you're going to, test some of these labs. So,
that's a good point.
Okay, great. So do you have any questions for me about any of that?
Yeah, I think it's interesting that once a day, I haven't gone to that. Usually when I titrate up, I'll start at like the 200 BID or twice a day dose.
Yeah, it's just you have to get another prescription.
Yeah.
Right.
Yeah.
So
Makes it a little bit tougher. Yeah. But
yeah.
Very good. Have you seen much outside of those kind of major side effects with the Capi, other side effects that have been
I
concerning?
know we can see some creatinine elevation, and I have seen that. I think my clinic has become very comfortable with that. A lot of times we'll get a cystatin C, and that'll address it. If they're not having nausea, vomiting, diarrhea, if they're hydrating well, then I know it's probably that. But we've seen this with tucatinib. We've seen this with the CDK4/6 inhibitors.
Yeah.
So I think the other thing is counseling patients on avoiding grapefruit. Many don't enjoy grapefruit anyway, so you don't have to worry about that. But drug interactions, and making sure that they let us know if their doctor has been, prescribed them any new medications.
Sure.
But yeah, I do feel that overall it's pretty well tolerated. And just really identifying the right patient for the right treatment and what to combine it with. Because I do like, if there's a co-mutation, I do want to try to combine it to target both ESR1 and the PIK3 pathway alteration as well.
Yeah, and you mentioned the epilisib drug before, and I think when I talk to providers sometimes about TrueCap, they say, well, it's similar to the epilisib, I can't prescribe it. But I think when that drug first came out, we had a lot of difficulty with managing side effects in our population. And again, the study that led to its approval, really did not include patients with, diabetes or even kind of pre-diabetes. So I think once that drug kind of hit the real world in our patient population, it was a very difficult drug to give because of toxicity. So, I feel like, TrueCap has, some bad rep sometimes in the community just because providers are familiar with using epilisib in the past. Yeah. So I do think it's much more tolerable than the epilisib drug was when we were using that as our only, way to target that pathway. And so when I talk to other providers, I kind of go through all the things we've talked about in terms of trying to help patients manage side effects. But I agree. I think if you can, counsel patients appropriately and stay on top of things from the beginning, I think most patients will tolerate this drug okay.
And generally seeing them regularly early on, just as with the CDK4/6 inhibitors, we're seeing them every other week. Initially, we're getting kgs, if needed for, ribociclib. And so kind of starting off, I think one thing is that many of our patients, after they've been on the CDK4/6 inhibitor, many times we're not seeing them so regularly, right?
Correct,
They've been on it for a long time. It's kind of on cruise control right now. Things have shifted, where it's a new dosing schedule. It's the side effect profile is a little bit different from what they've been on. So there tends to be that angst of, oh, I'm going to have diarrhea now and rash and diabetes and then just the counseling on the diet, right? So that tends to be more of a lifestyle impact.
It is, yeah. And they have to come in, every 28 days for the Fulvestrant, which,
Right.
some patients in the past were on the, the CDK.
Right.
And it's just sometimes if my patients are doing really well, I may even see them every, 2 to 3 months.
Yeah.
So it is
Yeah.
a change. You're right.
Yeah, no, absolutely. So, in terms of, sequencing beyond that, and just, now we have, like we mentioned earlier, we have imlunestrant and elacestrant, we have vepdegestrant, we have, the ADCs. You mentioned earlier, if somebody has endocrine, or not necessarily endocrine resistant disease, let's say that they have rapid progression, but there is that PIK3CA mutation or that pathway alteration. Would you ever consider coming back? Like, let's say you've switched to a TDXD or trastuzumab deruxtecan or an ADC or whatnot, and then would you come back at some point to additional endocrine strategies? And I think the question also here is, when do you consider endocrine resistant versus, sensitive disease?
Yeah, those I think are great questions that a lot of us kind of grapple with. Even on clinical trials, sometimes those definitions can vary from one trial to another. So, I think we take into account all those things in terms of, pace of progression, location of progression, the initial ER positivity, was it, a ER positive 20% tumor or 100% tumor? Even the grade, I think, is something to consider from the beginning. So taking into account all those things, if I do have a rapid progressor, whether they're coming off first line or second line, I may, prioritize an ADC in that situation just to try to get better control of the situation. A patient's very symptomatic, potentially it's liver disease or, just rapid progression in multiple sites. The question about coming back, is a good one. I think that's something I am consistently thinking about, but, I haven't had a lot of success the few times that I've done that in terms of patients who are kind of on the ADC chemo pathway now, tend to have more resistant disease, and trying to kind of bring them back to an endocrine therapy-based pathway in the future. I haven't really seen a lot of success with that approach. And it is attractive to, have a patient, take a break from, potentially an IV, chemo course and say, well, let's go back and see what we can do. And, it sounds nice, but I just, in my hands, I haven't found it to be all that effective against those tumors generally. So I don't know. How about yourself? Have you had any?
I've certainly had those patients that have had metastatic disease for a decade.
Yeah,
right?
sure.
And so anytime a new therapy comes up, then you're like, oh, let's try this. So we've been on all of the ADCs, or one patient had a complete metabolic response in elacestrant and then had an infection. Imlunestrant just got approved. We're like, oh, let's buy some time and go on the imlunestrant, right? So I certainly have those patients that I would naturally start with endocrine therapy strategies. And then when I feel that the disease is no longer endocrine sensitive, then that's when I'm switching over to ADCs and chemotherapy and kind of follow that trajectory generally. But I do have those patients that they may still have endocrine sensitive disease. It just, we didn't have those options available to them previously. And so we moved on to chemo, and now we're maybe circling back or using abemaciclib, after they've had palbociclib or ribociclib. And I have some patients that are like, I'm not going to do chemotherapy, or I'm not going to do any infusional therapy. And so they've been on all 3 CDK4/6 inhibitors. And so really trying to, again, milk out as much as we can of the oral strategies. So it's definitely a lifestyle change when you're going from orals to IV, placing a port, a hair loss, those types of things.
Yeah. That's a good point. I mean, the path of discovery, or the discovery, just the number of new drugs in the last 5 years has been amazing. And I think that's one thing that's important. We do have patients who are long-term survivors with metastatic disease, and just not forgetting that they may not have, had access to these drugs, years ago when they progressed. So
Right.
it's an important.
They don't fit the patient population for the study.
Correct.
Right. And so sometimes they'll ask, what's the progression-free survival expected?
Yeah.
Well, I'm like, well, we've had numerous therapies,
Mhm.
whereas in this situation, it was 1 prior line or 2 prior lines. So if you had to summarize where capivasertib fits in the treatment, landscape, what would you say?
Yeah, so I generally try to look at using TrueCap in the second line for most of my patients, but as we've talked about, there are certain situations where patients may move in and out of different treatments based on their rate of progression or other factors. But the Capitella 291 study was mostly a second line study. I think there were a small number of patients who had up to 2 prior lines, so technically third line, but most of the patients had second line treatment, and I was impressed with the results of the study for that patient population, and so I usually kind of stick to that, but as things evolve, as we get more data with combination therapy, with oral SERDs and such, it may be something that changes over time, or as you mentioned, we may find a better partner for Capi than Fulvestrant, and so that may alter where we use it as well. So it's definitely a dynamic landscape.
And what advice, as we're closing, what practical advice would you give another oncologist who's considering this therapy for their patient?
Yeah, I think, in the community, we still, I think, are struggling a little bit with just the testing. And so I think that's the biggest number one thing is any patient with metastatic estrogen receptor positive breast cancer needs to have NGS testing, preferably for me on tissue. But the availability of ctDNA and liquid biopsy is very important for these patients now too, to monitor for development of resistance with ESR1 mutations. So I think number one is just to make sure that that providers are doing the testing to identify these potential patients. And as we mentioned, about 50% or so patients are potentially going to be eligible and have a mutation in the pathway, whether it be PIK3CA, AKT, PTEN. And then, when we talk about this option, making sure that that we counsel, the providers about the potential toxicities and how to talk to patients about that, and how to monitor with close monitoring for these, the onset of hyperglycemia, diarrhea, the concerning rash issues. So, I think for providers who haven't done it before, there's a little bit of a learning curve. And I think after they, kind of treat their first few patients and identify some of these toxicities and manage them, they will feel more comfortable. And I do think it's been biased a little bit by previous drugs in the space, but I do think this is an improvement in terms of the toxicity profile over what we've seen before.
Yeah, no, I completely agree. I think that a lot of times your prior experience can kind of meld how you see things moving forward. And, when you're in the academic setting, a lot of times I enrolled patients in Capitella 291. And I could tell if my patient was on it, right? And so you can start to develop that experience over time. So when it's ready and it's FDA approved, then you've already had that experience.
Yeah.
But when it's protocol based, you can go back to the protocol and say, okay, what do we do now? What do we do now? And so you learn that during the course of the study. But certainly when a new therapy becomes available, recognizing, these are the things that I need to keep in mind to know, A, is my patient eligible? We don't want to take away a potential treatment option, and know the A1C difference. So I think that's critical. And then really understand what are the things that I could do to help mitigate some of the side effects and prophylax against. So the antihistamine, monitoring the A1C, considering dietary counseling, potentially metformin. One thing that we mentioned, I try to avoid insulin, metformin, but potentially considering like SGLT2 inhibitors instead of insulin, because we know that activates that pathway as well. So again, these types of nuances develop over time and experience. So I think the insights that you've offered have been really helpful. Yeah. Thank you very much.
You're welcome.
Great.
Great conversation.